Alright, chapter 21 is going to be endocrine and hematologic emergency. Endocrine orders have awareness that diabetic emergencies can cause autoimmune statuses, and then we will review the anatomy, physiology, pathophysiology, assessment, and management of acute diabetic emergency. Hematology will go over the anatomy, physiology, pathophysiology, assessment, and management of sickle cell crisis and clotting disorder. So the endocrine system influences every cell, organ, and body function. Endocrine disorders can have many signs and symptoms. Hematologic emergencies are rare in most EMS systems. However, they can be difficult to assess and treat in the pre-hospital setting. Anatomy and physiology review the endocrine system is a network of glands that produce and secrete hormones. The major components are the hypothalamus, the pineal gland, the pituitary gland, the thyroid gland, and the thymus gland. The parathyroid gland, the adrenal glands, the pancreas, the gonads. So hormones that have special regulatory effects on other organs and systems. The endocrine glands secrete and release chemicals such as hormones inside the body. The main function of the endocrine system is to maintain homeostasis and promote permanent structural changes. The pituitary gland is located at the base of the brain, and it's divided into the anterior and posterior regions. 6 of its hormones stimulate other endocrine glands: HCTH, folate stimulating hormone, growth hormone, prolactin, and thyroid stimulating hormone. HCTH targets the adrenal cortex and causes it to secrete cortisol. Thyroid gland secretes hormones in response to stimulation of the thyroid gland by the anterior pituitary gland. It secretes thyroxine when the body's metabolic rate decreases, stimulates energy production in cells. It secretes calcitonin, which helps maintain normal calcium levels in the blood. Travels to the bones where it stimulates the bone building cells to absorb the excess calcium. The pancreas is considered both a endocrine gland and an exocrine gland. The endocrine component secretes hormones from cell groups called the isolates of Langerhans, and it secretes the polypeptide hormones, insulin, and somatostatin. The role of glucose and insulin. Glucose is the major source of energy for the body. Without glucose, the brain cells rapidly suffer permanent damage. Insulin is needed to allow glucose to enter individual body cells to fuel their functioning, except for the brain itself. Insulin is responsible for the removal of glucose from the blood for storage as glycogen, fats, and proteins. When blood glucose levels are elevated, isolates of Langerhans secrete insulin. Insulin increases cell membrane permeability and mediates the transport of glucose across the cell membrane into the cell. The cells use glucose to produce energy through a process that includes glycolysis. Insulin also stimulates the liver to store excess glucose, and the skeletal muscles store glycogen for later use by the body. When the body glucose levels decrease, alpha cells release the hormone glucagon. Glucagon raises the blood glucose level and brings the body's energy back to normal by stimulating the liver to convert stored glycogen back into glucose through the process of glycogenolysis. If stored glycogen levels are depleted, the cells begin to metabolize fats, proteins, and other non-carbonate sources, producing new glucose, a process called gluconeogenesis. Alright, some pathophysiology of the endocrine system. The endocrine disorders can be caused either by hypersecretion or insufficient secretion of the gland. Hypersecretion presents an overactivity of the target organ regulated by the gland. So insufficient secretion results in underactivity of the organ controlled by the gland. Hypothyroidism or hypothyroidism are two serious illnesses of the endocrine system. Most of the endocrine emergencies will be related to diabetic emergency secondary to abnormal insulin secretion. Hypothyroidism and hyperthyroidism increases metabolism, while hypothyroidism decreases metabolism. Diabetic or diabetes is a metabolic disorder now thought to be associated with a group of complex diseases with many causes. Diabetes, gestational hypoglycemia, diabetic ketoacidosis, and hyperosmolar hypoglycemic syndrome. The end result is hyperglycemia, and it's characterized by polyphagia, polydipsia, and polyuria. So, diabetes is where the body is unable to sufficiently metabolize glucose. Okay. Mellitus refers to the presence of glucose in the urine. It's responsible for life-altering complications, decreased kidney function over the time, increased risk of atherosclerosis and coronary artery disease. So some very microscopic deterioration of vessel walls results in swelling of the basement membrane cells. CDA disease, stroke, hypertension, damaged vessel walls of the eyes causing swelling, wall weakness, and obstruction. Neuropathy affects peripheral nerves, causing diminished sensation and function in the extremity. So any pre-existing condition will be more difficult to manage. There is a lot of life-altering complications that come with diabetics, and especially the neuropathy. You have to be really careful with it because sometimes over time a lot of these patients do lose pretty much all feeling in their extremities, especially the lower extremities in the feet area. They will sustain injuries pretty easily. Both chronic and acute complications are associated with diabetes. If it is left untreated, diabetes results in the organ system dysfunction, wasting of body tissues, and death. So there's two forms. Type 1 is formerly known as juvenile onset diabetes. Is the type we'll go over yet. Type 2, formerly known as adult onset diabetes. So pre-diabetes is now recognized as a warning sign that may proceed to development of type 2 diabetes. Type 1 is an insulin-dependent diabetic or juvenile onset diabetic because it's generally affected children in childhood ages. So it has a hereditary predisposition. The environmental factors may play a role. The body develops auto-antibodies that incorrectly identify the body's own tissues. The rate of beta cell destruction is variable. Latent autoimmune diabetes in adults is a variant of type 1 diabetes that occurs in adults older than 30 years. In addition to daily insulin injections, strict dietary control must be observed. Increased activity or alcohol consumption can result in low blood glucose levels. Insulin pumps provide control of the blood glucose levels and better quality of life for these patients. And insulin pumps are coming in a variety of ways that they can monitor glucose levels for these patients. So don't be surprised. I've seen them now on the arms, and a lot of them can monitor over their phones. They actually get warning over the phones nowadays too. So you may want to ask where their pump's at. So some people still wear it on the belt, around the belt line, but don't be surprised if they're on the extremity also. Most common form of diabetes is type 2, the adult onset. Body becomes resilient resistant to insulin production typically develops when a person is middle aged, although the disease is becoming more common in younger people. When glucagon levels remain high, excess amounts of glucose are produced, resulting in high blood glucose levels. Symptoms of untreated type 2 diabetes is fatigue, nausea, frequent urination, thirst, unexplained weight loss, blurred vision, frequent infections, and slow healing of the wounds, being cranky, confused, or shaky, unresponsiveness, and seizure. So, weight loss is an important factor in helping to control type 2 diabetes, and metformin is the most commonly prescribed medication for the management of type 2 diabetes. Pre-diabetics, identified in people who have certain risks associated with type 2 diabetes. Blood glucose levels or hemoglobin A1C levels are above normal levels, but not high enough to be diagnosed as diabetes. The goal for diabetic patients is A1C levels of 7% or less. Some risk factors include older than 45 years, being overweight, family history, being African American, Hispanic, Latino, American Indian, Pacific Islander, or some Asian American racial or ethnic backgrounds, and gestational diabetes or having a birth weight or giving birth to a baby who weighs more than 9 pounds. Also, being physically active fewer than 3 times per week, losing 5 to 7% of the patient's body weight, and getting at least 150 minutes of physical activity per week can prevent or delay the onset of type 2 diabetes. All right, gestational diabetes, glucose intolerance, that can occur during pregnancy. But for most women, gestational diabetes will resolve before delivery. Blood glucose crosses the placental barrier. High levels of glucose enter the fetus and increase the fetal production of insulin. This does not create birth defects, and the management usually includes diet modification, exercise, and blood glucose testing. However, it can lead up to insulin administration during the pregnancy if not cared for correctly. Hypoglycemia, often as a result of having taken too much insulin, too little food, or both, results in hypoglycemic crisis, insulin shock. Counter-regulation is the body's natural defense ability to maintain blood glucose at a appropriate level. First line of defense is to reduce insulin production and increase glucagon production. The second line of defense is secretion of catecholamines by the adrenal gland. Stimulation of the autonomic nervous system generates stimulus that allow production of counter-regulatory hormones to increase. Then the liver uses these products to make new glucose for the body in the process of gluconeogenesis. In patients with type 1 diabetes, the insulins do not make insulin. In patients with type 2 diabetes, the pancreas can generate insulin. So these patients can suppress insulin production from within their own bodies. The lack of glucagon response makes the body more dependent on epinephrine to overcome the effects of hypoglycemia. These patients usually experience trembling, a rapid heart rate, rapid shallow respiration, sweat, and a feeling of hunger. So 9 out of 10 times these patients have autoimmune status. You'll see the shallow respiration, and they will profusely sweat. All right, hyperglycemia with diabetic ketoacidosis occurs when the blood glucose levels remain elevated and corrective mechanisms have failed. It can be because of excessive food intake, insufficient insulin dosages, infection or illness, injury, surgery, or an emotional state, stress state. A crisis is usually results in a diabetic coma and a state of unresponsiveness resulting from several problems. Onset may be rapid or gradual, and repeat episodes of hypoglycemia will cause several physiological changes that have detrimental long-term effects. So when serum glucose levels rise above the tolerable levels, the diabetic ketoacidosis and hyperosmolar hypoglycemic syndrome occur. I talked about the effects up there earlier, just to kind of review some of the causes, and these infection, injury, alcohol use, emotional distress, and illnesses such as stroke or myocardial infarction. So, the loss of water in large amounts causes the classic symptoms of uncontrolled diabetes and the 3 Ps. So polyuria, polydyspnea, and polyphagia. When fat is used as the immediate energy source, ketones and fatty acids are formed as waste products and are difficult for the body to excrete. Large quantities of ketone bodies in the bloodstream cause a decrease in the body's pH, resulting in metabolic acidosis. Ketones are responsible for the sweet, fruity breath odor associated with DKA. If proper fluid rehydration and insulin are not given, ketoacidosis will progress to unresponsiveness, diabetic coma, and eventually death. Patients in DKA are still deeply comatose. Signs and symptoms of hypoglycemia versus hyperglycemia. You get the blurred vision, the polyuria, polydyspnea, polyphagia, orthostatic syncope, frequent infections, skin ulcerations. So it will cause nausea, vomiting, to increase urine output, possibly tachycardia. Kussmaul respirations are very classic with hyperglycemia. Make sure you understand Kussmaul, warm, dry skin, and dry mucous membranes, and that fruity odor of ketones on the patient's breath. If they are still alert, they may complain of abdominal pain and sometimes a fever. The respiratory rate is usually elevated and tidal volume is increased because of the ketonemia, acidosis, and to relieve excess burn of CO2 in the body due to the metabolic acidosis. DKA results in both Kussmaul respirations and metabolic acidosis. In patients with type 2 diabetes, DKA is rare because insulin is still present, and with increased duration of type 2 diabetes, a loss of pancreatic insulin production may occur. All right, this table right here is in the book, and it compares hypoglycemia with hyperglycemia. All right, hyperosmolar hypoglycemic syndrome occurs principally in patients with type 2 diabetes, characterized by hypoglycemia, hyperosmolarity, and the absence of substantial ketosis. Highly concentrated blood as a result of relative dehydration. Some signs and symptoms include hyperglycemia, autoimmune status, drowsiness, lethargy, severe dehydration, thirst and dark urine, visual and sensory defects, or deficits, partial paralysis, and muscle weakness and seizures. DKA and this usually overlap, and they can be observed at the same time. It usually develops in patients with diabetes who have a secondary illness that results in reduced fluid intake. So, some patient assessment stuff that you'll find with diabetes. These patients usually have silent or painless heart attacks. They maintain a high index of suspension and treat patients aggressively. So these patients, pain sensories are usually very low. They do not and will not feel pain the same way as as normal people will feel pain. So these patients may complain some different complaints. However, you always want to double back and look at their cardiac stability also. So, go ahead and do a 12 lead with these patients, please, just to make sure you don't have any kind of cardiac involvement with their signs of it. Okay? So, in this thing size up, evaluate the thing's safety, ensure the personal protective equipment is readily available. Reliable. So, be very, very careful with insulin syringes on the bed stand insulin bottles in the refrigerator or plate of food or glass of orange juice are important clues that may help you decide the problem. So, don't be surprised if you see little 1cc syringes laying out everywhere. This may be a sign of something else. However, it could be a legit their insulin syringes. So make sure there's no trauma involved. Some patients, they'll find them on the floor or something like that. So you may have to possibly think about trauma and spinal mobilization of these patients, especially if they're unresponsive. So do a rapid scan. Patients with mental status suspect a low blood glucose level, identify the life threats, and provide life-saving interventions, and determine the level of consciousness using the AFP scale. Investigate the true complaint the patient has eaten, but has not taken their insulin. Hypoglycemia is more likely. If the patient is taking insulin but has not eaten, hypoglycemia is more likely. If they are not thinking or speaking clearly or unresponsive, attempt to obtain a medical history from family members or the bystanders, and physical signs may guide you in determining whether the patient is hypoglycemic or hyper. All right, get your sample and ask them, in particular, do you take insulin pills to lower your blood glucose? Have you had your usual dose of insulin today? Are you on the sliding scale? You may want to ask that question too. Make sure that they're taking it correctly. A lot of people, their machines may mess up, or they may not realize that they didn't check it correctly. So, have you eaten normally today? Have you had any illness or unusual amount of activity or stress today? So, you may want to ask the patient or the family when their last meal or insulin dose. Any vision changes, headaches, dizziness, or bleeding, and a recent change in the patient's bowel movements or eating habits. See if there's any tingling, numbness, or swelling in extremities, and check for emergency ID devices that may have one. On any assessment of the unresponsive patient, the bullet for it needs to have a full body exam. Look for problems or injuries that are not obvious on the unresponsive patients. They may have sustained some type of trauma also. The secondary assessment will focus on the patient's mental status and ability to swallow, protect the airway, get your GCS scores, vital signs, get a complete set. If abnormal vital signs, the blood glucose level is too high or too low. So the patient may have abnormal vital signs and normal blood glucose level. So glucometers measure the blood glucose level in the whole blood using either capillary or venous samples. Read and understand the operator's manual before you use it, and the normal range for glucose level in the blood in a non-fasting adult and children is 70 to 120. Blood glucose level in neonates should be higher than 70. All right, reassess the diabetic patient frequently. Monitor their airway and be alert for potential vomiting, especially if glucose has been administered orally. It can cause nausea also. Document each assessment, your findings, the time of the interventions, and any changes in the patient's condition. And the basic administration of glucose on serial readings. Keep hospital personnel informed. So basically, place this patient in a position of comfort. If they're unresponsive with no trauma, I would possibly place them in the recovery position in case they do vomit. Get your aligners on more saline and measure the blood glucose level immediately and initiate treatment. If the reading is less than 60, or follow your local protocol. Glucagon is administered 1 milligram IM with a greatly increased recovery time. If the patient's condition dose does not improve after a dose of dextrose, if you suspect a narcotic overdose, consider using Narcan. Transport unresponsive patients to Pine or in the lateral recumbent or recovery position. If there are indications of increased ICP, transport the patient's head elevated to a 30 to 45 degree angle and make sure it's midline. Keep the mouth and pharynx suction free of secretions and vomiting. So, if you suspect hypoglycemia, go ahead and try to get your IV access, and just note if you do give dextrose 50%, that is a very thick solution. It's basically sugar water in a ampule, or correction, a syringe, and it can be very hard to push. So a bigger bore IV, such as anything above a 20, 18, things like that, it does make it easier to push that drug through. Also, you can push it through 22 and possibly even 24, but it is going to be very difficult. All right, immediately increases the blood glucose level. Glucose or glucose gel, 1 tube or 15 grams. These do come in a variety of dosages. 15 grams. I've seen anything like 25 grams, something like that. So, do not give sugar-free drinks that are sweetened with saccharin and administer oral glucose. They say this stuff does taste pretty bad, so you usually want to have something also there for them to drink. However, these patients need to be alert and able to swallow and maintain their airway. Okay, you do not want to cause aspiration in these patients. So if you don't think that they can maintain their airway, do not give this drug to them. All right, IV dextrose. If hypoglycemic patient is or has autonomic status or is unable to swallow, contraindications include the presence of increased intracranial pressure or possible intracranial bleeding. So you may want to check the pupils just to make sure. Administering glucose in the presence of hypochloremia worsens the effects of low potassium. The dosage is 12.5 to 25 grams in adults and 0.5 to 1 gram per kg dose via slow IV push of D25 for children age 1 and older. 200 to 500 milligrams per kg of D10 solution for the neonates and infants. So, please give dextrose by IV push while carefully monitoring the infiltration into local tissue. Insert the IV line with the largest catheter and the largest fang. Attach an IV bag of an isotonic crystalloid solution such as 0.9% normal saline. Check the IV line carefully to confirm that it is patent and flowing freely. Inject a test bolus for about 10 to 20 ml of normal saline. Open the IV line wide. Crimp the line superior to the administration port and administer 12.5 to 25. And you need to follow your local protocol on that. So when administering D50, draw back on the syringe to observe for blood return. Recheck after 1/2 of the dose has been given by pulling back on the plunger again to check for blood return. And then flush the line. Okay. Be very, very careful with dextrose. D50, it can cause tissue necrosis. If you suspect that that IV site has infiltrated, please discontinue administering this drug. But and also make sure that you document everything. Okay. But before you do that, please make sure you call and get orders from online medical direction. If it's not part of your local protocol. So, management of the hypoglycemia patient or DKA is usually glucose level more than 250 milligrams per deciliter. The goal of DKA is to start the rehydration process and to correct the electrolyte acid-base abnormalities. Maintain the airway and administer oxygen, and be alert for vomit and hesitation reading. So you gain IV access, administer 20 mL per kilogram bolus of acetonic crystalloid solution, and for signs of dehydration. Follow the pathway for dehydration, all mental status, complete advanced airway management as early as possible if needed to. Cervical spine immobilization, if it's, it should be considered for all unresponsive patients, especially those if you suspect some type of trauma-related event. Get a blood glucose level, possible IV, large bore, and in a patient with heart failure, renal insufficiency, give fluid sparingly. So, you want to treat these patients with the 20 mL per kg, but make sure you're checking very frequently lung sounds to make sure that you're not causing fluid back up in the lungs also. Okay. Hematologic emergency is the study of the blood. That's what hematology is. It talks about and studies red blood cells, white blood cells, platelets, individual proteins involved in the bleeding and clotting cascades in the hematopoietic system. Hematologic disorders refer to any disorder. Hemolytic disorders refer to disease processes that cause the breakdown of red blood cells. Hemostatic disorders refer to bleeding and clotting abnormalities. Hematology, blood and plasma, functions of the blood to transport oxygen from the lungs to the tissues and carbon dioxide from the tissues to the lungs. It carries nutrients to cells throughout the body and removes waste products of metabolism from the cell. It transports hormones to their target organ and transmits excess internal heat to the surface of the body to be dissipated. It also carries defensive cells and plasma is a straw colored fluid that is 92% water and 6 to 7% protein. The remainder consists of a variety of other elements, including electrolytes, clot factors, and glucose. And it makes up to about 55% of the total blood volume. Red blood cells, erythrocytes, 99% formed elements in the blood within the RBCs. Iron-rich hemoglobin is responsible for carrying oxygen to the tissues, and the production occurs in the stem cell. Oxygen attached to hemoglobin gives blood its characteristic red color. White blood cells, called leukocytes, provide the body with immunity, and it's derived from the stem cells. And there's several types of white blood cells. Platelets are your thrombocytes and are responsible for clot formation. There are approximately 2/3 of the platelets circulating throughout the blood. The rest are stored in the spleen. They're derived from stem cells and platelets from the initial plug following vascular injury. All right. Bone blood forming organs and red blood cell production occur in the bone marrow, and it is found in most long bones, pelvis, skull, and the vertebrae. The liver produces clot factors found in the blood, filters blood, and removes the toxins, and it is essential for the metabolism and homeostasis. Also, the liver is very, very vascular. Has long Also with the spleen, it's very vascular, filters and breakdowns of red blood cells, helps produce white blood cells, and it is important in the homeostasis and infection. So there's a lot with blood classification and several different blood types. So classification is used to make sure of compatibility and prevent medical problems during blood component replacement. Um, there's type O, type A, type B, and then there's type AB. Blood contains a secondary antigen known as the Rh antigen. Transfusion reactions. Some patients may have previously received blood transfusions. It's also important to determine the blood type of the patient so that the type of blood received is correct. If a patient receives a blood type that is different than his or her own, a transfusion reaction may occur. Blood reactions occur rapidly and can cause severe circulation collapse and even death. When a patient receives a blood transfusion, monitor the patient very closely for the first 30 to 60 minutes. And usually in the hospital setting, that nurse is required to be one-on-one with that patient for the first 30 minutes. Sickle cell disease is the most common inherited blood disorder. Its primarily affects African Americans, Puerto Ricans, and European populations. The average life expectancy is 42 years for men and 48 years for women. The disease starts with genetic defects of the adult type hemoglobin, HbA. Defective RBCs have an oblong shape instead of a smooth round shape, making them poor oxygen carriers. Sickle cells have a much shorter lifespan than normal erythrocytes, predisposing the patient to anemia. The odd shape may also cause red blood cells to lodge in the small blood vessels, causing a thrombosis. Defective red blood cells may migrate into the spleen, causing it to swell and rupture, and it may also result in a plastic crisis, a hemolytic crisis, or a thrombosis. Vaso-occlusive crisis results when the blood flow to the organ becomes restricted, causing pain, ischemia, and often organ damage. It usually lasts between 5 to 7 days, and it's obstructed circulation to the spleen. Acute chest syndrome is a vaso-occlusive crisis that can be associated with pneumonia. Common signs and symptoms include chest pain, fever, and cough. Vaso-occlusion in the brain may also result in a CVA. A plastic crisis is worsening of the patient's baseline anemia, causing tachycardia for lower and fatigue. It may be caused by the paravirus B19, which affects the production of red blood cells. Hemolytic crisis, an acute accelerated drop in the patient's hemoglobin level. So to the left, you have normal red blood cells, and to the right, you have that oblong shape, those little pink ones, sickle cells. So in an acute crisis, patient may have substantial pain resulting from congested vessels. They do not allow for passage of oxygen and nutrients into the tissues and joints. They may experience frequent infections, which can lead to sepsis and death. With time, various organs may be destroyed as circulation is impeded, and may have mild dehydration, cardiomegaly, and many other complications. Patients with chronic sickle cell attack are vulnerable to severe life-threatening complications. Potential complications of sickle cell disease, CVA, gallstones, jaundice, and this list here. All right, anemia or red blood cell level that's lower than normal is associated with some type of underlying disease process. Iron deficiency anemia is the most common. In children, it is most related to premature birth or low birth weight. May sometimes be caused by inherited hemolytic disorder, It may also be caused by hematologic disorders resulting from the deficiency of the enzyme known as the glucose 6-phosphate dehydrogenase. Most common type of acquired anemia develops when the flow of red blood cells is disrupted owing to problems with blood vessel lining and blood clots. In autoimmune disorders, red blood cells are destroyed by the body's own antibodies. It can also have serious consequences for people who have traveled to high altitudes. Patients will report feeling worn down, having no energy, or feeling as if they have overexerted. Some may have angina-type chest pain related to decreased oxygen availability to the heart muscle. Other common conditions include leukopenia and thrombocytopenia. So clot disorders, thrombosis is the development of a blood clot occurring in the arterial or venous blood vessels. Symptoms are related to the part of the vascular system in which the clot occurs. So thrombophilia, tendencies to develop blood clots. Common medical problems, the thrombosis may manifest as the formation of a blood clot in a blood vessel or in one of the chambers of the heart. Pulmonary emboli, secondary to deep vein thrombosis, are the leading cause of death in hospitalized patients, and many patients receive anticoagulant medication. So some risk factors include recent surgeries, impaired mobility, CHF, cancer, respiratory failure, being overweight, smoking, and oral contraceptive. Hemophilia is a genetic bleeding disorder in which clotting does not occur or occurs insufficiently. The body is unable to develop spontaneous clots as normal, and it results in increased bleeding time. Usually it's predominantly in males. There's two types: hemophilia A, most common type, low levels of the factors 8. Hemophilia B is deficiency in factor 9. Signs and symptoms of acute or chronic bleeding can occur at any time and may or may not be life-threatening. Spontaneous intracranial bleeding is common, and that's usually the most common cause of death. Substantial acute bleeding episode requires hospitalization for transfusion, and the patient may exhibit signs of hypoxia owing to the reduction of oxygen carrying capacity. DIC may result from any number of life-threatening conditions, and it progresses in two stages. First, free thrombin and fibrin deposits in the blood increases, and platelets begin to aggregate. Second, you have uncontrolled hemorrhage results from the severe reduction of clot status. The mortality rate is very high in these patients. Signs and symptoms commonly associated with DIC are progression towards this coagulopathy. So, seeing size up, consider seeing safety, mechanism of injury, nature of illness, assess the hazards for the need for additional help. So make sure you are wearing your gloves, eye protection. Patients experiencing vaso-occlusive crisis are often in extreme pain and will benefit from administration of analgesics. Primary survey, always perform a thorough, careful primary survey, full body scan, airway breathing, maintain SpO2s at 94% or higher. If they are less, high flow to some type of an increased heart rate usually represents a compensatory mechanism. So be aware that even minor trauma in these patients can result in bleeding into the airway, increases airway compromise. So check their circulatory status. Do you suspect hemophilia? Be alert for signs of acute blood loss. Note any bleeding of unknown origin. Patients with hemophilia may exhibit signs of hypoxia or shock. So fully assess these patients quickly, and rapid transport will depend on the severity of the patient. Investigate the cheek complaint, get your sample, check physical signs such as swelling of the fingers, toes, jaundice. Also, look for changes in level of consciousness. And have you ever had a crisis before? When was the last time you had a crisis? How was it resolved? And have you had any kind of illness or unusual amount of sleep or stress lately? These be performed on scene en route to the emergency department or not at all. Systemically examine the patient, focusing on major joints at which these cells congregate and obtain your patient's baseline balance. Get your aptitude skills and use pulse oximetry if it is available. We assess the patient frequently and document each assessment, your findings, the time of the intervention, and any changes in the patient. Consider O2 fluids, initiate IV replacement is needed, transport pain management is necessary, and place the patient in position of comfort. You may need to use analgesics for these patients, antibiotics to prevent infection, and blood transfusion as required. In the case of anemia, check to monitor the airway and the patient's breathing. For patients reporting chest pain, call early for paramedic backup. Identify DIC and establish treatment early, and be optimistic but honest with the patients and their family. That's the end of this chapter. In fact, if there are stores of glycogen to draw from. So it comes in 1 milligram ampule. The dosage is 0.5 milligrams per children who weigh less than 20 kilograms. It's the same for adults for children who weigh more than 20 kilograms. And it should be used in conjunction with dextrose whenever possible. Also, just kind of think outside the box sometimes. If you do give the PPT, you may run into a situation where you notice that these patients may not be able to take care of their glucose for an extended amount of time. This glucagon IM may be a way for it to metabolize slower and help keep the glucagon levels high in the body, so that these patients, you may give them time to get somewhere to get a bite to eat to help keep it metabolized, their sugar up.